Good afternoon, and thank you again for joining us for today's webinar, Innovation, Health, and Housing, Oh My. Today's presenters are Jeremy Carter and Dan Lavelle. Jeremy serves as the Chief Housing Officer at Community Human Services in Pittsburgh, a large multi-service agency focused on basic needs and housing services. Under his leadership, he has developed and launched 11 new housing programs in the past 3 years, focusing on innovative funding and strategic partnerships. Jeremy oversees all administrative functions of the Housing Assistance Programs Department. By leveraging different funding sources and establishing unique partnerships, Jeremy has been able to increase housing assistance funding by 250% over 3 years, with the department serving over 2,100 people in a housing crisis per year. Jeremy has an education background in social work from the University of Pittsburgh. Dan is the Director of Government and Business Relations Government Programs at UPMC Health Plan. He is responsible for providing leadership for regional and local partnership opportunities, such as initiatives with healthcare providers for those with intellectual and developmental disabilities, and housing-related partnerships for health plan members. Dan led the recent merger of United Way of Butler County with the United Way of Southwestern Pennsylvania. He serves on the board of directors for the United Way of Southwestern Pennsylvania, where he is the chairman of the Butler County Local Operating Board, the United Way of Pennsylvania, and Community Human Services. He earned a Master's of Science in Healthcare Policy and Management from the Heinz College at Carnegie Mellon University in 2010, and a Bachelor of Science in Policy and Management from Carnegie Mellon University in 2009. Thank you, Jeremy and Dan, for joining us today, and I'll turn the presentation over to you.
Great. Thanks, Colleen. Well, welcome, everybody on the phone. I hope you can hear us all right. So we'll get started right now with our presentation. I think it's exciting. We'll probably try to, I know we have an hour. We'll probably try to get done with our portion within a half hour or so we can have quite a bit of conversation. We look forward to hearing what your thoughts are. This has certainly been a learning process for us at UPMC Health Plan, and we're fortunate to have our partners at Community Human Services. We can go to the next slide.
So if you haven't already noticed, this is an interactive. We're going to try to make it a little interactive webinar. So if you would like to participate, all you have to go is slido.com, either on your phone or computer. Type in CHFS for the code. And we're going to integrate some live questioning throughout the webinar. It's also a place where you can also list your questions, which we'll look at the end of the presentation. Let's see. So for those of you who want to participate, just kind of a test question, what do you hope to get out of this webinar? In just a few short words, it's fine. I'm going to go ahead and put in those thoughts, if you will, right now. Pizza. Well, can't really do that.
Gosh, I would love that too.
Next question. What best describes your role? Just so we can get an idea of who all is in the audience today. Wonderful. All right, so it looks like most people are housing homeless providers, but it's good to see some some government or foundation funders and some health plan staff. So this is great. Thank you, everyone. Dan, I'll kick it back to you.
Great. All right, so just for a quick little overview of who we are at UPMC. So we're based out of Western Pennsylvania, and we are the largest employer, non-governmental employer in Pennsylvania. We're an integrated delivery and financing system. You can see on the slide here that we have 4 kind of main divisions. The one that I come from is insurance services, where we have our health plan and where we have a good bit of our government program business, which is all Medicaid and Medicare. So we're growing. We're moving across the state, which is exciting, and to many of your communities, and I think this is our partnership with CHS is one that we look to hopefully continue and leverage a little bit further. Go to the next slide. All right, just a little bit more about our insurance services division. So basically what we have is, what we'll be talking quite a bit about is our Medicaid and special needs plan program. This is what the target population for our housing intervention here. But just a quick little bit of an overview on this slide. We don't need to go through too much, but our big thing is we have about 3.5 million members now, and we have a business all from behavioral health to commercial benefits to workers' compensation and quite a few others. So we can move on to next slide, Jeremy.
Right. So just a little overview of who we are at CHS. We kind of have multiple different prongs into our basic needs services. So you can see the other kind of departments that we have at CHS. The one that I'm involved in is the housing assistance program. But as a whole, CHS has been around for about 50 years in Pittsburgh, operating on about $10 million budget. And we serve about 8,000 people per year through all of those different departments that you see there. Within the housing assistance programs, we have kind of developed a continuum within our agency with everything from emergency shelter to kind of bridge housing for behavioral health to rapid rehousing, permanent supportive housing, diversion programs, as well as community assistance programs as well. And so within the housing assistance programs, we serve about 2,100 people a year. A lot of that is in our rapid rehousing programs. And we are experiencing a really exciting time of growth where we've been able to launch 11 new housing programs in the last 3 years. And one of them is kind of this newer program that we'll talk about towards the end of the program with UPMC. Next slide. Dan.
Sorry, I was on mute. So I think for us, in terms of kind of the way that we look at we look at things for us as a health plan. I mean, we have started to think quite a bit about how we're going to make investments in social determination of health, and I think for us, the hierarchy here is exactly something that we've looked quite a bit at. And I think this is how we're starting to think about things a little bit more. We're not just an insurance company. We want to make sure that we're providing, the best environment, the best support, and the best care that we possibly can, and understanding the needs of our population. So I think that take one here is interesting, but for us, I think what we've seen is that the other two into basic human needs of Wi-Fi and battery are one I know I need for my own self, having a 3-year-old daughter. But I think for us, and to kind of get into this conversation, in terms of a hierarchy of needs, I think we really have, plugged housing in here quite, I think quite well, and one that we realized for us being in dominant Medicaid and special needs plan, which are people with dually eligible for Medicare and Medicaid plan out here, especially in Western Pennsylvania, is that a good number of our individuals are housing unstable, whether they're chronically homeless or living on somebody's couch and moving from place to place. And I think for us that affects overall health care, and I think in a way that we really see a lot more now, and that's why we're determined to make some more of these investments and make some of these partnerships that we've done with Jeremy and Community Human Services overall. So that's kind of the way that we've thought about it. So moving on to the next slide, I think, for us, and Jeremy will be able to talk a little bit more about this, especially from the Community Human Services perspective, but how we've wanted to do things at UPMC Health Plan, and especially with our with the population that we serve, I think we think about housing as health in two buckets. So one of them being kind of overall programs that support our exact members. So we have about 425,000 Medicaid members across the state, and so we look at programs that we can do that we're going to talk about here in a minute. One being the Cultivating Health for Success program that's focused on serving just specifically those members. But then in kind of a different bucket is our overall community benefit work that we're looking to do. So this is kind of some of the tax credits that we make investments in, even with some of you who might be on the phone from community organizations across the state. And then also how we kind of are looking to take what we've done and partnerships that we've made and kind of see how that best practice model might turn into legislation on the national level or through administration and regulatory efforts to kind of allow us to make some a little bit more pooled investments of our dollars and dollars from other agencies to really tackle a program like homelessness. So we'll talk about that for a little bit later on. But going into the next slide, Jeremy, go ahead.
Yeah, I was just going to give a little bit of background for everyone on how this program actually came to be before we get into the specifics of actually what it is. About 10 years ago, CHS, UPMC, and our local continuum of care came together and said, basically, UPMC has this group of people experiencing homelessness who are also very high utilizers of what we are now calling unplanned care. And so 10 years ago, we started what then was called Shelter Plus Care under HUD, and now has transformed into permanent supportive housing. And what was interesting about that is at the time, it was the first program of its kind in the country to really focus on Shelter Plus Care for people with physical health conditions, where the majority of those HUD programs were specifically for mental health. But what we saw was the physical health components were the ones that were really sending people back to the ER and being readmitted without any housing stability. So the thought was, hey, if we could all come to the table and everyone put money into this solution and give people stable housing, the thought is the healthcare will go down. And so that was kind of the basis of this, and it has continued for the last 10 years into this, and that's kind of how we got to this point. So for the current program, when we talk about Cultivating Health for Success, that's the program between CHS and UPMC. You have to be HUD homeless, but not chronically homeless. And you have to have the UPMC for You Medicaid or Special Needs Plan, and have at least 1 year of high health expenditures so that UPMC can kind of get a good idea of what those health costs are and what the opportunity is to decrease those savings, and just be willing to work with the care managers and the social workers to kind of develop the health plan and the goal plan for housing. And just really looking for people who are able to live independently. Now we are really very much housing first, so we try to have as little barriers as possible to get into the program. And if someone isn't able to live independently after we house them, we'll look for different solutions. But that's pretty much the base criteria there. And the kind of dynamics of the program is we have about 25 members enrolled at any given time. For your HUD people, that's the point in time count for our program. So those 25 people are the ones that are clients, are the ones working directly with UPMC and CHS staff for permanent housing. All of our housing for this program is scattered site, so we do not have fixed fixed buildings. They're all in the community with private landlords. And then to actually run the program, we get a permanent supportive housing contract from our continuum of care, and then UPMC gives us a contract for the supportive services, which will help cover cover our social worker costs, some client assistance, supportive services, and things like that to actually get the program running. Because we don't get any supportive service for this program to help with that. Next slide. So kind of give you a kind of a visual of how everything works together. On the left, you have kind of the CHS staff. That's the housing-focused social worker that we hire. And then you have two staff from UPMC. One is a mobile clinical nurse, and the other is a community health worker. So the thought is the three of them working together almost on a daily basis, well, pretty much on a daily basis, really helps the continuity of care, which we have seen to be one of the strong points of what makes us a true success. So the components are the housing social worker will really help with looking for housing, moving them in, the rental assistance, sustainable housing plans, landlord mediation, delivering some of those supportive services, while the mobile nurse will really do a lot of the care management and the care plan, medication management, helping them get connected to different specialty services that they might need. And they can also do some testing in home. All of these visits happen all in home. And a lot of the times, all three staff will actually, sometimes all try to do the home visit at the same time if that's what the client wants. And then the community health worker from UPMC kind of has a similar role to the social worker, where they can help with appointments, whether that's traveling, transporting, or making the actual appointments, following up, going to the appointments with them, but also really linking them to those community resources that we want people to plug into for long-term sustainability. On a daily basis, they do kind of these huddle calls just to see, what's going on, who's seeing who today, anything we need to act on. And then biweekly, the frontline staff, those three staff, will meet kind of a case conference to see what's going on and how they can work together and leverage the resources and services from both agencies to really serve that person well. And then monthly, all the staff, including administration and supervisors, will all meet for a full case conference, going over every single person. And that's a really rich time for everyone to really come to the table, because we have people from billing, from community care, from housing. And so it's a really good time for everyone to do that case conference, at least monthly. And the last thing that I think really is helpful is to build that continuity of care is having a really good relationship between CHS and UPMC with data. I know data sharing agreements can get tricky, but the huge benefit from this is that we get alerted when a member is sent to the ER or gets admitted, so that that day or the next morning our staff can connect with the UPMC staff and say, hey, Bob went in the ER, what do we have to do? So that it's a really fast and collaborative approach to a crisis. Next slide. So I think I wanted to hit on some of these things because these are the best practices that we use for this program, which I think has a significant impact into the success of how we do things. But not only that, these are philosophies that CHS uses, but UPMC also has really latched on to these philosophies. And I think one of the great things of how our partnership works well is that UPMC understands our goals. And, sometimes having a large healthcare provider kind of match their philosophies with a grassroots, progressive kind of housing provider don't always match. So some of the things that we really focus on is, again, that housing first component of really trying not to have as many prerequisites as necessary to come into the program. But also with housing first and harm reduction, we're not kicking people out because because they're using drugs. I mean, there's a large population of these clients that are actively in addiction, And our approach to that is how can we help you use more safely for yourself and people around you, and continuing to give them education and resources for addiction, but ultimately it's the client's own decision and goal if they want to do that, and we want to respect that. Motivational interviewing and trauma-informed care are just kind of these philosophies that guide our case management, and I think UPMC has really picked up on it too. If you don't know motivational interviewing, I highly suggest you look into it. It's a very simple concept of how we do these interventions or just talking to the people that we serve in a really unique way that really gives the power to the client in that conversation. Trauma-informed care is really just looking at, homelessness is really traumatizing, and we want to make sure that we are not re-traumatizing people's lives just to get services. So we have to understand how trauma affects people and integrate that into how we talk to people and how we engage with them. And lastly, progressive engagement is just our kind of guiding model that we use of really starting with the lightest touch possible and then continuing to add on and increase or decrease when the participant needs the services, but really recognizing one model does not fit all. Next slide.
I think, Jeremy, just to add a little quickly to what you said, I mean, I think we value you so much as a partner, I think, because, in so many ways, we can't do this, nor do we want to, and, I think in some ways, as a health plan, I think it's important for you all to know on the phone that, we cannot pay for rent as a health plan, especially in our we just can't do that. And I don't know if we would want to do that, but there are many things that we can't do. So what we really needed to do was find a partner like CHS. There's no way we could have this program without that. And, I think that's kind of been, for us and for all of you who may be looking to other health plans or even, whoever it might be. Just like I think understanding that regulatory environment and what we can and can't do, I think has helped us to kind of get to where we are. And we have such a degree of trust with CHS, and our team that we have that, there's just no way it could be done, otherwise. I wanted to just say that before we got into some of the results.
Great. Thanks, Dan.
Yeah. Do you want me to start with this one, Jeremy? Results here?
Yes, please.
Yeah. So here, and you can add in. So I think at a very high level, we're fortunate, as Jeremy mentioned, on the data sharing and the data analytics side, to really be able to look at the programs that we are working on, really track our members, and especially because we're talking 25 members a year. What we were able to do was kind of have a 5-year study, really that kind of dug into how are we doing. So it was successful in many ways. I think in a lot of ways it's like a one program, whereas exactly what we wanted to have happen actually happened. So I think the first bullet's an important one. So 85% of eligible members were successfully housed. So I think that's really a huge one, because we saw the markers and we were able to kind of see in a few slides. We'll talk to you a little bit about how long it really takes for somebody to really change their trajectory. And our big goal here is to reduce unplanned medical care. We're not looking to reduce appropriate care. Somebody who might have incredibly high spend, they may have a cancer diagnosis, something of the sort. We're not looking to do that. It's really only unplanned care and really trying to get the individual set up for more appropriate care. So I think it's pretty self-explanatory. We saw a pretty significant drop in overall unplanned care and a significant increase in primary care and specialist visits, which is exactly what we wanted to see. And we also saw an increase in pharmacy costs, which in a lot of ways is exactly what we want as well, because we want people taking the right medication and continuing to adhere to that. So that's been just such an immense positive. So the next slide is just a little bit more into the numbers here, and I think it's important to really see that in this first graph on the left-hand slide or left-hand side is that an individual, when they enroll in the program, they really have got to be housed to really see this unplanned medical care or medical cost trend decrease. So really, it's naturally, they could get enrolled in the program, and receive some of the kind of care management supports. But for us, even for our staff, they've got to be in a stable housing environment to really be able to see the overall increase. in appropriate care and the decrease in unplanned care. I think the other slide is a very simple rate, facility rate. For that for us just means ER inpatient stays, which is just a massive marker for us in terms of results of the program. So this really looked at, we had a couple different analyses, one following the members and the other one kind of looking at a comparison group for us. And really, why these results were important for us, we're going to make this and we're going to do this because it's the right thing for our members and we love this partnership, but this is the beginning of making a real, a business case for how housing and health are tied together and how we all can create more partnerships like this. And I think this is one of the, at least in our health plan world, this, ours is one of the first examples of really being able to show, that exact business case for this. And I think it really helps us, and it has helped us in thinking about how we're going to expand this program, moving forward. So this next slide is just kind of another one to kind of look a little bit at, how these, the trajectory of these members, and just kind of really showing a stark comparison to those who are not in the program. And I think, we really talk about the, getting rid of ER visits as much as we possibly can, but they've got to be followed with that appropriate utilization, which I think is pretty neat and exciting for us.
And Dan, on that last chart, just for people to understand, that comparison group is very much representative of the current group in the program. They have housing instability and very high trends of unplanned care, correct?
Yes, absolutely. And I think for us, what we saw, it's unfortunate there even is a comparison group because, I think one of the things that we'll get into, and Jeremy, you can talk about it here in a minute, is the fact that, the eligible participants are really capped here. So we, that's why we wanted to look at how can we, make another, kind of program expansion here because we're only able to have a certain amount of people in the program, right? Anything else to add there, Jeremy, on the comparison group?
Nope.
Okay, great. And the comparison study, we just added another slide in here for you all to be able to see kind of the different ways we've been able to present the data. Obviously, the few pieces of information on the left side of the page, 59% more routine office visits in the comparison. That's obviously exceptional. And then the unplanned care drop is exactly what we want to see. So these are telling a similar story, and we just wanted to make sure that you all were able to see this. Jeremy, do you want to?
Yeah, so we wanted to do a little test here and see what you think, how long do you think it takes to really see significant medical savings once the client is housed. So I've opened up that poll for you and give you a couple seconds to kind of guess and take a stab at it. All right. So it looks like a vast majority of you think 3 or 7 months, and then a couple for 10 or 14. Very interesting. I think what we see is we do see observable decrease once they are housed. But on the next slide, Dan will talk about how at 10 months is really where we start to see significant savings.
Yeah, so we've really, and it was quite a neat analysis that our team did here. We really wanted to understand what was and this marker is actually going to be an important one for our expansion program and the pay for success element that we're discussing. We really saw that it's 10 months of stable housing. If you look at that, is where the trend starts to kind of move. So, I think that makes sense. It makes sense in some of our other, interventions. In a lot of ways, sometimes it takes even longer with some. Obviously, if you're on the right path once we get an individual enrolled in the program. But it was just interesting in the way we looked at it. So we now know that, that is such an important marker. So whatever we can do, and Jeremy's team does such a wonderful job to keep people housed in this program for 10 months. That's where it kind of starts. That kind of goes with some of the savings that we've really seen. I think overall, just to kind of give like a quick little nugget on the number of savings. So for us, what we saw was for individuals in the program who are in the program for a certain amount of time, an $8,000 per person per year savings on the medical side. But then we saw about a $2,000 increase on the pharmacy side. So the savings are around $6,000 per member per year, which is great, and that's wonderful. I mean, that's our goal is to get people to where then they have a new trend where they're kind of they reset their normal, and that's really our responsibility, and that's our mission is that we want to make sure people are getting the most appropriate care, and we just see housing as such an important piece in this 10-month figure is really where we want to be. Anything to add there, Jeremy?
Nope.
All right. I'll start this for 1 second because I want to kind of set the tone, and then Jeremy, please go through the piece. I think for us as a health plan, we realize that there are a handful of our other members who have housing instability who could really partake in a program and would really need, I think, and benefit from the program that we have, but we just weren't able to do it. So we really wanted to expand, and there was no doubt that Jeremy and Community Human Services was going to be the group that we did this with. And so Jeremy, why don't you talk a little bit about what we're going to do?
Yeah. So after seeing the success of the what we call the 5-year pilot program, both CHS and UPMC came to agreement that, yes, we want to expand this because we still have that group of people who still have the high utilization but are not meeting that HUD homeless criteria. So we want to really roll this out and bring it to scale. So we hope to bring it to scale by tenfold to 250 at some point. For 2019, we're going to shoot for about 100 members and then increase from every year after that. So when we started to think about this, we obviously had to get rid of the HUD Permanent Supportive Housing Grant because that's the housing criteria that really disqualified people who were qualifying from the UPMC end. So we have good relationships with the housing authorities. And met with them to kind of explain what we're trying to do and why this intervention would be really good use of housing choice vouchers. And so we were able to establish some partnerships there. And so when people come into this new expansion program, they will not have the HUD rental assistance from the Permanent Supportive Housing Grant. But they will have the rental assistance from the housing authority. And then we realized, this is a very complex kind of program to design. So we applied for some technical assistance and was awarded a technical assistance grant from the Corporation for Supportive Housing, who are just very knowledgeable experts on everything supportive housing and also pay for success modeling, which is really what this new program is that we're talking about, is kind of in this pay for success model. It's a little bit different, but definitely catching on. There's about 25 pay for success projects in the country right now, but it's a very unique intervention. Next slide.
Yeah, I think add to that, Jeremy. I think quickly, the neat part, for us as a health plan is that we have value-based arrangements with medical providers everywhere, based on outcomes. And this is one of the first times to work with Community Human Services, and it seems like we evaluated this, and I think it was something that that is neat and could potentially become a model for the country in terms of how a health plan and a community organization are able to work and make this kind of work together. So we'll see. It'll be neat. Go ahead, Jeremy. Yeah, agreed. There's a lot of pay for success projects that are really focusing on kind of criminal justice recidivism, some mental health, some physical health, but this is certainly kind of how we're designing the project and the purpose of it and the outcome.
is definitely one of its kind as a pace of success project right now. But I wanted to quickly talk about, this project is exciting, but at the core of it, we still wanted to make sure that a program of this scale is still going to tie back to community and systemic efforts. So one of those, and I say this because, a lot of people when we talk about this program get really excited and want to launch it, but I stress that it is a great program and a great model, but also important is making sure that it aligns with what your community, COC, and healthcare provider want to do. And so I just wanted to provide some of the kind of examples of how we aligned ourselves with those changes. Our Pennsylvania Secretary of Human Services, Teresa Miller, came out to our site to talk about this program on her statewide kind of Medicaid innovation tour to see what MCOs are doing in terms of utilizing Medicaid in innovative ways. And she was really supportive with this idea of really tying MCOs to housing and homeless providers for something like this. So we have really good support on that end. Also, although we won't be exclusively assisting homeless clients, we do expect that we will still serve those people because we're not excluding them. It's just any type of housing instability, which obviously includes homelessness. And so we also want to tie this program into what our COC is doing to try to prevent and end homelessness. And so we looked at kind of what the focus is, and one of the focus of that plan was to really tie Medicaid into homeless and housing programs to help offset those housing costs. And then really across the nation, we're talking more and more about using Medicaid. And again, like Dan said, Medicaid won't pay for the actual housing, the rent, but it's just kind of aligning the leverage and support of Medicaid providers and MCOs.
That's perfectly said, Jeremy. And I think that kind of reminds me on the basis of kind of systemic change. I think for us in an integrated delivery system where we have hospitals and doctors' offices across the state, another thing that we're hoping to leverage is really the collection of understanding who is housing unstable and how do we best collect that. And Jeremy's team does an exceptional job, and I think the health plan and healthcare industry overall can probably start to do a better job educating medical providers around what coding you can do. We're working with our direct care managers and our community health workers that are employed by the health plan to kind of ask some of these questions, to put this information in our care management platform so that we can really. I think our goal is to also effectuate change on the collection and understanding of who fits this bucket, and really to make sure that we're providing that kind of whole person support like Jeremy was talking a little bit about. All right, so we have only a couple slides left. I want to have enough time that we can have more of a conversation. So quickly, these final two slides are just a little bit about the other types of larger scale community benefit investments that we've made as a health plan. So we focus quite a bit on the state tax credits, the NAPs and the NPPs that a number of you I know are eligible for and work with other organizations who are as well across the state. I think it's exciting for us to think about how we can make some investments there to increase affordable housing, home modifications. We do a lot of work with lead abatement, and then other kind of wraparound services, a little bit similar to some of the work that we've done with Jeremy, but more on kind of a community-wide basis. It isn't exactly for our members, but it's important for us. We also have a partnership with a local kind of mission-driven real estate fund here in Western Pennsylvania, who's doing quite a bit of work to make sure that they're gentrifying in place, if you will. And I think that's something we want to continue to go on. And lastly, just to talk a little bit about where kind of health plans, we're trying to catch up, I think, to you all in the way you do exceptional, outreach to government stakeholders across, a large continuum. We joined a new coalition. Usually we're kind of members of just coalitions that are only our own. only connect in our own health plans or hospitals or whatever it may be. But we've joined a new group called Aligning for Health, which I think is neat, and some of you might want to, share a little bit more about this in another avenue to really think about how we can support an effort federally to blend and braid funding from different federal agencies to target a certain problem, whether it's for homeless, whether it's for disadvantaged youth, which is a program that was created under this past administration, which this is kind of built off of. There hopefully be more to come here, but it's kind of a way that we're looking to hopefully push some of this and then use this program that we have as an example of what you can do whenever you kind of partner. And we're already using dollars from different federal agencies. If you think about our program, HUD, being one, and then HHS being another, and then a few others in there. So that is it on that. I think we've come to the end, Jeremy.
Yeah, so I think we'll open up to questions. We already had 3 come in during the presentation. So Dan did kind of go over how much money is saved per person, but I wanted to give some specifics of the numbers Dan threw out. It was from the 5-year study, it was an average of $8,472 that was saved. And then if you take off the pharmacy cost, it's about $2,000. And so it was about $6,384 on average that was saved per person. Dan, do you want to answer that second question about the clinical care manager?
Yes. So that's a good question. So basically what we have is, and under the health plan, we have staff that are responsible for interfacing with doctors, so they don't exactly work for a medical provider like our prescribing physician there, but we have a couple different models that we use, one of them being a practice-based care manager approach, which kind of embeds one of our care managers, which is a nurse usually, or some other similar designation into a doc office, or a facility that is, where we have, high utilizers or just a ton of members. And then the other really is just what we more so have here, which is just people that are hired who are responsible for interfacing with the provider's staff. So that's kind of the relationship. They're very, very connected, but not directly employed by, no.
And what about the other medical costs that was shown in one of your charts? It was like other medical costs versus unplanned.
Yeah, it's a good question. So, I think to us, that is, so unplanned basically is emergency room. That basically the big bucket of that is going to be emergency room visits, and then the other could be other types of facility use, which would be going to urgent cares, going to an inpatient admission, which is sometimes unplanned, and then other times is a little bit more planned, so it's a little murky depending on how we talk about it. So really the unplanned, is driven by ER, and then the other costs are just kind of other facility visits that are experienced by a member. But again, the big goal for us here is to increase the amount of visits and increase the amount of dollars spent on primary and preventive services in a lot of ways, and then the rest we're hoping to decrease.
Dan, there was another question that came in, it's not showing on the slide. If there were no limitations to the capacity for this program, how many people would be qualified or would benefit? So what is the actual need? Dan, I think I remember the list that was pulled of people who were kind of in that unplanned care bucket, but also had some marker of a housing instability, was around, I think, 430 for just Allegheny County.
Yes, that's true. So, we have significantly more than that who have high unplanned care, where we're trying to, make sure that we get to the right type of care. But, overall, who might have housing stability, but for some other reason are going to the ER quite a bit more. But yeah, that's correct. So, we're looking, that's just in Allegheny County. And for us, just to give you all like a little bit of a marker, we've got, nearly 100,000 on Medicaid in Allegheny County. But certainly, a good number of those, are those who are working, as well as in the expansion population. So when you think about even in Allegheny County, and Jeremy, you could probably give the overall housing instability, homeless numbers. It was having 400 some individuals, mostly around the city of Pittsburgh, that need this is pretty eye-opening to me, and I think where the opportunity is. So, Jeremy, can you actually give the overview of what the homeless population looks like? I know it fluctuates.
We don't have numbers on housing instability. It's just really hard to kind of get that information. But as far as people who are homeless on the streets, it's about 100. But when you look at kind of everything, people in homeless shelters and homeless programs and, bridge housing and things like that, it's more around about 2,000, I think. But the housing instability piece is really interesting, and I think that just ties into I can go on a tangent about this, but just housing affordability. In Allegheny County, we're short about 20 to 30,000 units of affordable units, at the same time experiencing a significant growth in kind of luxury high-end housing. But I'm sure that's happening everywhere. Another question, are you using social determinants of health to determine eligibility for these programs or using other assessments? Dan, I can jump in real quick and then I'll defer to you. But for this new program, we are looking at all of those social determinants of health kind of in the intake and assessment. So we're looking at the physical, the housing, the social, income, and all of those different aspects to it. That's only to get a good idea of, the big picture of social determinants of health for this individual. It's not to screen them out.
Yeah, it's perfect. I wouldn't add anything.
Hi, Jeremy and Dan. We did get a couple other questions. One was, could individuals that receive this PowerPoint share with other nonprofits that offer affordable housing?
Absolutely. We, I won't speak for UPMC or Dan, but we are more than happy to share any and all information that we have learned about this program. Obviously, we have a lot to go off of the last 10 years, but even just kind of going into this new expansion program, we have learned a lot. So we're more than happy to send PowerPoints, documents, studies, whoever wants them.
Absolutely. I mean, I think, for us, one of the things I've enjoyed the most about this is learning a little bit about housing. I think it might actually be more complicated than healthcare. And, so I think please, and you all should know, especially even if you have questions about anything healthcare related and how we as a health plan and a Medicaid managed care organization fit in here, you can always ask. And, it goes without saying, but please, I mean, I bother Jeremy all the time about probably, rather mundane questions about housing. So, yes, please, go right ahead.
Great. And then somebody asked, what are the age ranges for services beyond 18?
So I'll just quickly talk about our membership, and Jeremy, you can talk a little bit about it. But just in terms of the program eligibility, I mean, you really, this is going to be, kids are not going to be in this one. I mean, you're going to have, you really just have to be on our Medicaid plan or our special needs plan, and we have people from 18 and above there. So those are the that's kind of the big one. It can go all the way up, honestly, because we have special needs plan members who are over 65. Because if you're dually eligible, you can be dually eligible for Medicare or Medicaid due to income, then due to a disability or whatever you may have, then it's kind of unlimited over 18.
Great. And somebody asked, do you have any programs in the Lehigh area?
So currently, in this type of program, no. We have done, and we have specifically tried to make this work in Allegheny County and with Jeremy and their team. So, and I think, but, both of us, I think we can say that we're looking to see if there's a way that we can kind of replicate or build from this. For us to do an exact program like this as a health plan, we really need to have a significant enough membership, which we're starting to gain in the Lehigh area. I will say that on one of the last slides, we have made a few, I don't have them offhand, but we have made a few of the kind of more tax credit investments, that are less, than a specific member program in the Lehigh Capital region. So I should have mentioned this early on, but for us as a Medicaid plan currently, the state's broken up in 5 zones, and we have the Northwest zone, the Erie zone, and the Pittsburgh zone, Southwest, and then the Lehigh Capital is our other zone that we're hoping to grow a little bit in. So we've started to think about it, but we do not have this exact program now.
Great. And we do have a couple more minutes for questions, so if you'd like to type them into the chat box, you can. Or if you'd like to unmute your phone by pressing *7 to ask your question over the phone, you can do that as well. And again, that's *7 to unmute your phone. All right, well, we haven't received any questions. And Jeremy and Dan, do you have any last-minute comments?
Jeremy?
No, just, stay tuned. We'll be sending out some updates and press releases as this new expansion program hits the ground running in just a few short weeks. Please reach out to myself or Dan if you have any questions on, trying to start something like this. We are not experts, but we have learned a lot in this process and are always happy to help other organizations and partnerships try to come up with some kind of model like this.
Amen. Perfect.
Great. Thank you,
Thanks,
Jeremy
everyone.
and Dan. And thank you, everyone, for joining us today. And as I said in the beginning of the webinar, we will be sending out a recording as well as the PowerPoint slides later this week. So thank you, Dan and Jeremy, again, and everybody enjoy your Wednesday.
Thank you.